I'm delighted to welcome you today to one of our October webinars for Staff Health and Wellbeing Month. My name is Kirsten Feehan, and I'm a Health Promotion and Improvement Officer with Dublin North City and County. This webinar has been organised with HR and our Health and Wellbeing Department. I would like to introduce you to Dr. Rita Galimberti. Dr. Galimberti has 25 years' experience in women's health and runs her own women's health clinic called Fem Plus in Roselawn, Dublin 15. Today, Rita will be talking about how to approach the menopause and how to plan your health when you age. You can ask questions throughout the talk, and we will do our best once Dr. Galimberti has finished to get through these. There will be a survey to complete if you have a few minutes at the end. If you complete it, you will be in with a chance of winning a One for All voucher. If you are tweeting about today's webinar, please could you use our tweet hashtag, which is hashtag StaffHealthDNCC. I would like to now hand you over to Dr. Galimberti.
Thanks very much, and thanks very much for inviting me. I'm delighted to speak about menopause. As you know, a lot of you might not know me, but I do run a women's health clinic in Blanchardstown. I'm very passionate about women's health, which is why I started this clinic. And menopause is one of my favorite topics because it's pretty much what I do every day these days. So I'm going to talk to you about menopause and how to take care of your health, because there is a little bit more in your health than just worrying about menopause symptoms. Now, these are just a few things that I know they're going to be sent to you as well, where you can find some of the education programs I do. I do a bit through social media now, which is a bit of a new experience for me, and that's the Instagram account I use. I also have a blog called menopause.ie, which I created years ago, which is just really a simple guide to menopause, and the other website is just a clinic site. A lot of women ask me always, when does menopause start and what is menopause? And when you ask patients, the vast majority of people is convinced that menopause is that time of your life when you have hot flushes and maybe night sweats and some other symptoms. And the vast majority of people do think that menopause finishes, so it ends at some stage, that you are on the other side, and a lot of women would sit in front of me and report, I'm now through with it. Unfortunately, that's not what happens, because menopause, and that's the medical definition of it, is when your ovaries stop working. And when your ovaries stop working, they stop producing hormones, estrogen in particular, and a few other things, but they never start to do that again. So menopause does last for the rest of your life. It never finishes. What does finish is the symptoms. And this process can happen in two ways. Can happen naturally due to aging, and usually it's around 50. For some unfortunate women, it can start very early, and they suffer of a thing we call premature menopause, which is usually defined when the ovaries stop working before age of 40. And then for some of the women starts for surgical reasons. They might have to have surgery for cancer, or they might have to have ovaries removed for gynecological problem. And obviously they don't have functioning ovaries anymore. And when that happens, your ovaries stop producing estrogens. And when that happens, there are consequences on our body, because there are receptors for estrogen in every part of our body. There is a long, long list of organs that have estrogen receptor. So there are some consequences and things that happen straight away, and we call them the short-term consequences. And then there are things that happen more in the long term. The short term is the symptom stage. So that's when people all recognize the symptoms. And that's what happens when the ovary usually is starting to malfunction, or they've just stopped working. Women have mood swings, they're irritable. A lot of women report to me and say, I don't feel myself. I don't know what's wrong, but I'm not myself anymore. I lose my temper. I give out to the kids for no reasons. I'm depressed. I've lost the joy of life. I don't know what to do when I get up in the morning. Some more symptoms are more recognizable. There are hot flushes, and if anybody has had them, they know exactly what they feel like and what they look like. And night sweats is another one. And they're not just feeling hot at night. It's a real sweat. It's when you wake up and you have to change your pajama, or you have to put a towel under you because the bed sheets are soaked. That causes a lot of trouble in sleeping, very often because you have had the night sweats and you had to change your pajamas, so it's very hard to not wake when that happens. And then some women report a lot of concentration and memory problem, which is, known as the more general term of brain fog. There are a lot of other symptoms, and a lot of clinics, and I know a lot of Facebook groups supporting menopause go around with this list now, which I personally hate. And it's called the symptom checker list, and it's basically a 2 pages list of things that has everything under the sun listed there. And the problem with this list are that a lot of these symptoms are just due to aging. They're not specifically menopause symptoms, but they occur at menopause because that's the age when they happen. And the confusing things that this list can do is that you might expect that all the things on the list have to get better if we start treating your menopause, which is not going to happen. For example, weight gain is one that is very common. But if you look at men and how men age and where they put fat on their abdominal region on their belly, they do exactly the same thing. So it's not a menopause thing, it is an aging thing. How do you know if you're in the menopause? Do you need to have a blood test? And just actually this week, I shared on my Instagram a post of a private clinic that was advertising doing all these blood tests for diagnosing menopause and understanding how the menopause can affect your health. Obviously, money-making thing, and I'm always very opinionated and say what I think about these things, and that's what I said on my post, because you don't need a blood test. The blood test is going to tell you absolutely nothing. We make the diagnosis of menopause on your symptoms, and for some women, the blood test is completely normal, but they have all the symptoms. So is this not useful? And it is just very, very confusing, because in the past, what used to happen is that women might have the symptoms, they go and visit a doctor, they have a blood test done, the blood test comes back normal, and the doctor will say, no, it's not the menopause, you're probably depressed, take an antidepressant. And that is why the blood test is confusing. And we have very, very clear guideline from the British Menopause Society, which is our main training body for menopause specialists, to say, do not take blood tests, they're not very useful, and they don't help you treating the patient. And the next thing is, what should I do about menopause? Do I need to worry about it? And the reality is that nobody dies of menopause. A lot of women go without treatment very happily. The hot flashes are not going to kill you, and the symptoms will eventually go. So to every single woman that sits in front of me to discuss menopause, I always say, you do need to decide what to do. The choice is not the same for everybody because we're all different. And the way the symptoms affect us is different for all of us. So you usually have 2 choices, and I call them plan A and plan B, not because one is better than the other, but just because I have to call them something. So plan A is when you decide to take estrogens, and that's the HRT, hormone replacement therapy. And if you do that, and your symptoms are due to estrogen deficiency, your symptoms will get much better. And that is a decision that only you can make, only the patient can make, because we're not all affected in the same way by these symptoms. And you have to tell us, how are these symptoms affecting your quality of life? And the most important thing to remember, which brings me back to the checklist I showed you earlier, is that the symptoms will all improve if hormonal related. So taking HRT will not fix your weight gain, even if it happens in menopause, because that's due to aging. There's other ways to fix that. And there are a lot of things on those lists that are not hormonally related, and they're not going to improve taking HRT. So that is really important, because you have to have realistic expectations of what the treatment can do for you. The hormonal therapy is quite simple, is based mainly in giving you estrogen, which is the main hormone you need. But if you take estrogen, you also need to take progesterone if you have a uterus, because if you give estrogen alone, you give women endometrial cancers. This used to happen about 50, 60 years ago when I started gynecologists. No, not when I started, but it was the beginning of HRT. They didn't know that you have to use two hormones together, and they had women who had more endometrial cancer. So now we know that you do need progesterone as well. And for some women, you need a little bit of testosterone. The important thing when you consider HRT is don't worry about the type. There is a lot of talks in these groups about this is better, the gel is better, the patch is better. And actually, estrogen is estrogen. They all do exactly the same thing. We all use body identical estrogens nowadays. And whatever is a tablet, a patch, a gel, a spray, it doesn't really matter. The two choices are to give it to you as a tablet form or to give it to you through your skin. And it has become quite common now just to use the transdermal route, but that's actually not that right because the oral route, which is the tablet, is still very good for a lot of patients. The difference between them is that the oral route does slightly increase your risk of blood clotting. So we don't use it in patients who are at risk. So these are patients who are overweight, who might smoke, or who might have other clinical risk factor for thrombosis. The transdermal route doesn't have that risk, but some women are very safe on the oral treatment, and we use it quite a lot, especially in the younger women, because it's cheaper and it's more convenient. If you don't want to take HRT, or if you cannot take HRT, for example, because you've had breast cancer, there are other treatments are available to you. For example, in the short term, for the hot flushes, there are other drugs we use. So don't think that just because you don't take HRT, you have no choice and no treatment available to you. And some women don't take HRT because they find that their symptoms are not bad, and that's absolutely okay. There is this school of thought coming from the UK mainly. There is a couple of clinicians there who are going a little bit crazy about HRT treatment, telling women that you absolutely have to take it, you're mad not to take it. And that is not true information. We all have a choice. HRT can do good things and bad things, and the choice is individual for you depending on what your situation is. But if you decide not to take HRT, be quite careful in spending money in so-called natural treatments because they basically don't do anything. And we do have quite good evidence and studies done on alternative treatment to show that they basically don't do anything. Some women take them because your friend or your neighbor is taking them and this tells you it's very good, and you have to remember that you might have different symptoms and it might have worked for her because actually she had very light symptoms, but your symptoms are bad, therefore it doesn't work for you because it doesn't work for most people. And the other important thing about this natural treatment is that when something is called natural, we are all led to believe that it's safe, so that is not, doesn't carry any clinical risk, but that's actually not true. First of all, because there are a lot of concern on purity of herbs in these compounds. There is no regulation for a lot of these compounds. Many people don't know that, but you could basically start making your own supplements tomorrow, put in a little bit of dirt from your garden and sell it, and nobody can say anything to you. And because it's not medical, it's not regulated. So you can actually say it does a lot of million things, and you don't have to respond to anybody about what you say. Also, for some particular natural treatment, black cohosh in particular, there have been some concern on renal and liver toxicity, depending on how much there is in it. And I tell you this because I know that probably like me, because I'm of a certain age myself, your social media might be bombarded by these ads that we see. And this is one that keeps coming up on my one. And this looks fantastic. It cures absolutely everything. Perimenopause, menopause, estrogen dominance, which is, by the way, is not a medical thing at all. It doesn't exist. PCOS or any irritating symptom that you might have. And they all use this really, really sneaky word that are very appealing to women, like hormone balance. We're going to balance you. And they're just marketing terms. You cannot balance anybody's hormones. It is impossible to do it even with HRT. So these are just completely false statements. This is another one that it's on the Irish market a lot. They're basically sponsoring any conference or any talk on menopause. Again, regulates hormonal activity. No scientific evidence whatsoever that these compounds can regulate hormone activity. And some women, some people like this lovely lady, which I'm sure she's a lovely person, do make an absolute fortune or a career out of this stuff. The problem is actually the long term, which is what nobody's worries about. And the long term worries me a lot because we're all going to spend nowadays about a third of our life in menopause because our life expectancy is better. And so it means that if you die in your 90s and you go to menopause in your 50s, a third of your life, or actually probably a bit more, will be spent without your ovaries and in menopause. And when that happens, because of the role of estrogen in our body, there are things that happen to us, and we become more at risk, for cardiovascular risk. We all know that we don't talk about heart disease and heart attacks in women a lot before the age of 50. Seems to be something that only affects men. But after 50, we don't do so well anymore, and our cardiovascular risk increases quite a lot. We also know that the bone density decreases and osteoporosis is much more common in women than men. And the third thing that happens is the changes in the vagina and bladder. So I'm going to talk to you about these three big problems because this is really where the issue is. It's not the hot flushes, but it's the long-term effect of aging and menopause on your health. And that is why you all need to make a plan. When people get a bit older and we're all facing a medical problem, usually the attitude that people have is, I see how it goes, and if I have a problem, I'll deal with it. We don't tend to plan for our health. Very few people sit down and say, okay, I'm going to do A, B, and C so that when I reach 18, 90, I'll be able to do other things. And that's what I spend a lot of time talking to my patients. We plan about other stuff. We plan about holiday, we plan about money, we plan about pension and retirement, but we don't plan about our health, which is the only important thing you have. Your money is no good to you, your pension is no good to you if your health is not good. These are the rates of cardiovascular disease. They're a bit old, these slides, but they haven't changed that much. And you can see that the first cause of mortality in women is heart-related. When I asked this question in webinars, in real conference, and I asked women, what are you worried about? Everybody's worried about cancer. Very few women worry about heart. And when you look at the percent of cancer there, they're actually quite small. Breast cancer is quite tiny. We're talking about death, not incidence of the disease. But the cardiovascular, it's over 50%. So it's a big problem. We know that if you start estrogen early in your menopause, you can reduce your cardiovascular risk. That is absolutely true. There are some data to show that. But the problem is that this is only the cherry on the cake. The major risk factors are not your having or not having your estrogen. Yes, that is a risk, but are the usual suspect, which we all know, and if you all work for the HSC, you should all be very familiar with these things, but they are always the usual things. Your BMI, your weight, your waist circumference. If you put weight on your belly, that's much more dangerous for you, your blood pressure, and your cholesterol level. And they're all things that sometimes people just don't check. It's very common for us when we do menopause clinic, we obviously check the blood pressure all the time. And sometimes we find elevated blood pressure and we tell the patient, look, your blood pressure is a bit high, we need to check it again. And patient would say, I never had blood pressure. When is the last time you checked? Oh, I have no idea, maybe 3 years ago. And this happens every day. So we're not trained to think, we're not used to think about these risk factors. We just think of cancer and we think of other stuff, but we don't think about monitoring what are the actually most known and most proved risk factor for a heart disease. And this is the reality. The vast majority of Irish people does not have a normal weight. A lot of them are overweight. There is a good bit that are obese, and the minority of us have a normal weight. These are Irish figures. Again, it's a little bit old, but I do this exercise in the clinic all the time. I count, and I did it last week just because I was giving this talk. The patient I saw throughout the week, day after day, and counted how many were normal, how many were overweight, how many were obese, and my numbers totally match these ones. And I would invite you to do the same exercise at work in the next few days. Look around your colleagues, look around your patients, and see how many people you see that you could say straight away they don't have a weight issue. And you probably find out that your numbers are very similar to mine. So why do we still have such a big problem if we know that it is dangerous and if we know it's a big risk factors? Why do we not do anything about it? And the reason why we don't do anything about it is because it's very hard. If it was easy, of course we wouldn't have a problem. And when things are hard, people try to make excuses. So I hear these things every day in my clinic. I have very heavy bones, which is not a thing because bones weigh the same for everybody. My metabolism is slow. Little bit of truth in that with menopause, and I'm going to talk to you about that a little bit later. Diets do not work for me, and that's usually for people that don't follow them. Or I cannot exercise because I hurt my back 2 years ago, my leg, my arm, my left toe. I hear these things every day. And last week I did a post on Instagram on this, which of course got me bad comments because that's what usually happened. And it was in relation to COVID. And it has happened to me on that week that 2 patients came in to me saying I was doing very well with my weight. Obviously, they do have a problem in front of me. I was doing really well, but then COVID happened and I couldn't go back to the gym. And COVID, the last lockdown was nearly 2 years ago. And the reality is that that is now an excuse because if the last 2 years, and I'm not talking about the poor people who had COVID themselves and got very sick because we know the long-term effects that can be very bad. I'm talking about people just using it as an excuse. And it's very hard to talk about these things because, of course, when I put that up, I offended people who told me I was underestimated COVID and all of that. So you can never win. You can tell a patient that they have cancer. You can tell a patient anything about the medical health, but when you start talking about the weight, it's a minefield and you have to be so careful because we're always afraid to offend patients. So it's very hard. We all want a quick fix. And really what I'm trying to do, and that's why I'm so passionate about this, is I'm really trying to change the mindset of people, the way you think about things. And when I talk to people about diet, that's usually what they see. They see it as a very negative thing of all the things they're not going to have and how sad that's going to make them. And really what I want people to think is to think about the plan and thinking that they have to decide if that's the woman they want to be when they're old and they want to be in a hospital or they want to be a superwoman who's super healthy. And some things are in our hands as a matter of choice. Not everything is. You can be unfortunate, you can get some form of cancer, and you can do nothing about that. But for a lot of things, it is a lot to do with what we choose every day. So how do we do that? The most important thing is your diet, not the exercise. That's why the COVID excuse is an excuse, because you could not go to the gym at all and just have a proper eating plan and you will still lose weight. And I said to you, I'll talk to you a little bit about the slow metabolism. It is true. It does become much harder in menopause for women and men because some of us develop a little bit of insulin resistance. Actually, a lot of us develop that. And insulin resistance basically means that the insulin, which is something that normally helps you maintaining your blood sugar level, will work against you and make you store away every molecule of sugar that you eat and put it in your belly, and then stops you from metabolizing and the stored fat and stops you from losing weight. So it does really feel like you're going on the treadmill the wrong way around. And a lot of women come in and I know they're trying. I'm not saying that all the women that have a problem do nothing about it. And they tell me, I've been doing all of these things and nothing seems to work. And that is the reason why we have developed a diet plan in the clinic, which are only starting next month. And it took me a lot of work to put this plan together. We did a pilot for our patients for the last year and a half to see what would work, what would not work. And the reason why I'm so passionate about this, because it happened to me as well. I've always been quite fit. I'm a runner. I always kind of been very good with my diet. But when menopause hit, I put on weight as well. And it went to my belly, and I wasn't very happy about it. It wasn't a lot, I have to be honest, but it was enough to, for change size. I have to change my jeans, and my clothes wouldn't fit anymore. And I did study and look into all the things that would work. So we did develop a more precise plan for menopause specifically, which is also a course to teach people what to do in terms of cooking and planning their food, and what are the good things and right things to do. The most important things, if you want to lose weight, you do need a plan. It doesn't have to be my plan, it can be any plan, but you do need a plan. And you need to have a goal. And this is essential, because otherwise you get these people that you see year every year, visit after year in the clinic, visit after visit in the clinic, who are telling you, yes, I have to do something about that, or I'm trying, and they actually never get anywhere. So you need to go from A to B, and you need a precise way and a precise plan to do that. And then you need to review your plan to see, is it working for me? Is it doing something? Am I making any progress? Because otherwise I need to change it. This is something that I find quite annoying, because there are plans out there that are very famous, and it's funny, when I was talking about the goal, you see people who have been going to Slimming World all their life, and it couldn't possibly be a good plan if you keep doing it all your life. Any plan you do, you should be able to stop at some stage. But this particular plan annoys me, because it gives people wrong information. Look at this. A bar of Twix is 12 cents. I'm not too sure why it has to be called Sims. It's maybe because it works very well in the Catholic Ireland population. And then instead, you can have all this free food, which is all free, and you can have as much as you want. But in reality, in the real world, which is not the slimming world, a bar is 248 calories, and all that food, it's over 1,500 calories. So it couldn't possibly be true that that is bad and that is good, and you can eat as much as the good food as you like. That is not realistic, and that's why these plans don't work. So enough of the weight, but actually, before I go off on the weight, I just want to tell you one more thing. Every time I give these talks, every time I talk to a patient, every time I give a webinar, I've estimated that about half of the people that listen will agree with me. Some people just don't agree, and that's fine. A lot of people would nod away and say, yeah, that sounds right. Maybe 10 people will go away and start doing something. And as average, out of about 100 people, 2 people will change something realistically in their life. And that is something to think about. Now, I want to talk to you about your bones as well, because I told you your bone density decreases. And osteoporosis is something that doesn't seem to worry people as much. It doesn't sound nearly as scary as cancer. But actually, osteoporosis, it's a very serious problem. And for the ones of you who work in that field, you know what I mean. If you have a fracture, an emergency fracture of your hip in your say in your 70s, you have about 30% chance of dying. That's quite a lot. And you could be absolutely fine, but because you've had that fracture, you just die. And that happens. You don't die of the fracture, you die of the complications. And it does affect 1 in 2 postmenopausal women. So it is so common for women. And if you look at the risk, that's why we have this perception that it's not dangerous, but actually your risk of having a fracture in postmenopause is much greater that you combine the risk of cardiovascular and breast cancer. So it is quite high, but we don't worry about it. I'm not too sure why that is. So if you need to decide what to do about that, you need to know, first of all, where you are and what your risk is. The doctor that you attend, your GP or your menopause specialist, will do a specific assessment to see what your risk is. And that is based on your family history, your risk factors, if you were a smoker, if you were taking steroids. There's loads of things we look at. And sometimes we also do a DEXA scan to see what your baseline is and how are you starting. But when you have a problem, then again, you need to decide how to fix it. And from a medical treatment, you have HRT, which has been shown to reduce the risk of osteoporosis. And that is why I have menocomplex waste of time decided. Those alternative preparations that are so sold for menopause that are going to do everything for you are not going to fix your bones, even if they contain vitamin D, even if they contain calcium. This is just not enough. There are other medication if you cannot take HRT. There are osteoporosis medication that we use. And the difference between the HRT and this other medication and the other stuff, so just taking calcium or natural supplements, is that when you have osteoporosis is because the balance between the two types of cells in the bones, which are called osteoblast and osteoclast, is changed. The osteoblasts are your little builders. They're the one that build up new bone every day. The osteoclasts are the destroyer. And when the estrogens go, what happens is that the destroyer work better and quicker than the builders. That's what your balance is wrong. So the drugs, the osteoporosis drugs and HRT fix that problem because they bring the builder to work a bit better again. Vitamin D and calcium in particular, are just the bricks. So the way I explain it to my patients, it's like if you have a big pile of bricks there, but the builders are not going to do any work. So if you just take the bricks and nobody uses them, that is not good to you. And the other things that affects the bones modulation, so that does help the builders to do their job, is exercise. But is not any form of exercise, is resistant exercise. So walking is fine for your heart, but doesn't do anything really for your bones. And it is really important to think about incorporating some form of resistant exercise in your day. Things like the gym if you want. I don't particularly like the gym. Pilates, yoga. You can do little weights at home. There's loads of different ways to do it, but you need really to think about, am I going to fix this, and what am I going to do? And again, I need to change your mindset, because if I talk about exercise, this is what you're thinking about. Early in the morning, the gym, again, is going to make me really sad. But really what I want you to think about is that you can decide to be a woman like this when you're old. That's what, early osteoporosis looks like. If it's bad, it's worse than that. Or if you want to be like this woman who is very happy, and the choice is in your hands, because you need to make the choices that are right for you. There is a very interesting documentary that it's on Netflix at the moment. I don't know if anybody of you has seen it, but I really invite everybody to look at it. And it's called "They Live into 100, the Blue Zones." And it's researching showing an area of the world where people live longer. And the message about that, and it was very interesting for me, because there is this whole hype now about HRT being something that everybody absolutely has to take. And there are so many other factors that affect your health. And the HRT, as I said, it's only the cherry on the cake. In the documentary, you see that a lot of these people are men, so hormone is not a factor. And they're not rich, so they're not people who have DEXA scans, they're not on HRT, they don't have very fancy drugs, but they do the right thing day after day. They move every day. The one in Japan is very interesting because people sit on the floor, so they have to get up from the floor, which is actually quite a good exercise. I always make it people do when I give this talk in live to people. And they do that every day. And they also eat well every day. So it's not the fancy stuff, but it's the normal things that will keep you alive and healthy for longer. So watch it, because it's very interesting, and I'm using it quite a lot in talking and discussing problems with my patients. This is what I call living below or above the residential line. So the green line is, if you go below the green line, you're in a care, you're in a nursing home, which could be nice or not nice, depending how lucky you are. But really, the way you want to live your life is the blue line. You want to be as well as you can, up as long as you can, and then die. What you don't want is the slow decline, bit by bit, that being overweight and heavy bend bones will bring you, like happens in the red line here, bit by bit. Now, and finally, the last things I've talked to you about changes in the vagina and bladder, and I'm going to talk to you about sex. And usually I say at this point, that's why you're all here. I know, don't you think I don't know that? And we're going to talk about sex in menopause. One of the very common symptoms women report to me during consultation is having a low libido. And it is very common, but when we talk about libido, we need to understand how libido works for us. And unfortunately, for us, it's a very complex problem. For women to be aroused and wanting to have sex, all these things have to happen, and they have to happen in the right sequence. So we're very, very complicated creature, and this is scientifically proven. We don't get aroused very quickly like that. I mean, it just happened maybe a little bit better when we are younger, but certainly at this age, that's how it works. And I add in my list of those things that has to happen that it has to have emptied the dishwasher as well. You might have your own thing to add there. While for men, it's much easier. It's on and off, and that's all they need, unless they have any medical or problem or other diseases, but that's usually how it works. And that's why it's hard to match us. I told you that 1/3 of your life will be spent in menopause, and there will be changes in the vagina and bladder. And this is something that people don't talk about a lot, and that I'm very, very passionate about. And it's a thing called vulvovaginal or urogenital atrophy. This is something that women don't seem to talk about so much. We all talk about hot flushes, and we all talk about moods and brain fog, but again, we're not talking enough about the vagina. And it is something that can present with painful sex. It is something that presents with chronic discomfort for some women. Some women, they develop recurrent infections, or they think they have a recurrent infection. They come to me and say, oh, I think I have thrush all the time. And they don't. They just have vulvovaginal atrophy, which makes you sore and itchy, but you don't know why it feels like that. But the important thing about this is that it does happen to everybody. It is not like the other symptoms that some women have more and some women have less. It will happen at some stage to every single woman. It is a given, like getting gray hair, like getting wrinkles. Myself and my colleagues can guess a woman's age looking at her vagina, and believe it or not, that is possible because the changes are visible. You don't see them because you don't look at your vagina or other people's vaginas as much as I do, but I can tell you that it happens to everybody. So there are solutions to painful sex, and the most important thing is that you do something about it. The first thing is to use lubricants, which are absolutely essential in menopause. There are different types. Some of them are water-based, some of them are silicone-based, but they all, there's a wide range of things on the market. I personally think the silicone-based are better because they do stay in position a little bit longer. But what is really, really important is how to use them. And I do spend a lot of time with my patients to discuss how to apply them. A lot of women would apply them on the male partner, and that's actually not any good to you because it will rub off very quickly. What you want to do is you want to have your finger full of lubricant, put it in your vagina, and try to coat the vaginal walls with the lubricant solution, because that's what it's supposed to be. And the purpose of doing that is that you create a gliding film that will stop any friction and any pain. But that's not enough. The other thing you should do is using vaginal HRT. Now, this is essential for women who decide to go for the plan B. Remember at the beginning, I said you could decide to go on HRT, not to go on HRT, or maybe you cannot go on HRT. So if you're part of the plan B group, the no HRT group, you can still, and you definitely should use HRT for your vagina because it doesn't affect you systemically. It is very safe. It's only absorbed locally, so we also give it to women who have had breast cancer, and there's basically nearly no contraindication for its use, and it is a very, very important part of your treatment. So don't forget about this, especially if you are not taking HRT, and do not wait until the symptoms are bad, because what happens sometimes is that people do sail through menopause, don't take HRT, and start having symptoms of vagina atrophy in the late 50s, early 60s, by the time they come and see me, the situation is quite bad. And to revert that, it takes a long time. So it is much better if you decide not to take HRT that you start using something vaginally at the beginning of menopause, because these will help your vagina, will also help your bladder, and will also reduce slightly your risk of prolapse. The other important thing about them is you need to keep using them. In the past, this was a thing that used to happen in the hospital. We used to give it to women to use for 6 weeks or 3 months, and that was it. Use it and then stop it. And that was so stupid. I don't know why we did that, but these were the guidelines many years ago. But obviously, the minute you stop using them, you revert back to zero and you go back to what you were like before. So it doesn't make any sense, but you can use them long term until any age, and you shouldn't really have any worry about doing that. And the third thing about treatment, there's a new treatment available, which is laser treatment. And I want to spend a little bit of time on this, not because I do it, but because I am really astonished by the improvement in women's life that this treatment has made. When you read about laser, and that's something that I fight with my colleagues outside in the hospital quite a lot, people tend to talk about laser in general, say the laser is dangerous and some lasers are bad. And there are some studies published that have been talked about a lot this year about laser not making any difference. And they were all studies using CO2 laser. Not all lasers are the same. There is CO2 laser, which is called Mona Lisa, which is absolutely not any good at all. And there is erbium laser that works in a completely different way. And there are scientific studies to prove the erbium laser, as showed in a randomized study, a difference in treating patients. It's an approved treatment in the rest of Europe because this randomized study has been published last year. And my own experience has been fantastic. Only last week, I had 2 women last Friday who gave me a hug and told me my life has changed. Thanks very much. And these are people who could not have any penetration at all. You couldn't even touch their vagina with your finger because they were so much in pain. And now they experience normal sex. So being able to give back a normal sex life to these women, it's really rewarding. And I really made a big difference in my practice. The other thing about sex and libido is that we need to talk about sex if you want to discuss libido. One of the things that is given a lot is testosterone, and there are clinics in the UK that just give you testosterone because it's supposed to be this fabulous drug that will make you have good sex without any effort at all. And because of the slides I showed at the beginning, that's absolutely not how it works. If your libido is low, I need to ask you questions. I need to understand what is going wrong. Did you have a sex problem before? Some women, amazingly enough, had bad sex for many, many years. And they come to me thinking that testosterone will fix it. And that's not going to happen because you're going to have the same quality of sex you had before. If it was bad before, it's still going to be bad. We need to talk about sex scheduling, which is one invention that I have that I'm very proud of. And sex scheduling is when you decide where in your week you're going to put sex. And you might think that that is not the way it should be because it should be spontaneous and it should happen like that. But that's not how life works. And many women are put off by having sex because they're tired, because they're thinking about having sex, what is really a runtime for them in the week because they're busy with the kids or whatever has happened. And they don't actually make time for it. And you need to make time for it because arousal takes time. It takes quite a long time for the vascularization around the clitoris to reach its peak. And if you want sex to be pleasurable, you need to schedule in and you need to think about it. The other big advantage of scheduling sex is that it puts you off the hook when you don't want to have sex. And a lot of women feel guilty about not having sex with their partner. And the fact that they have it on the scheduling gives them a lot of freedom for the other nights to do what they want. So think about it. I think it's a very liberating thing for women to do, and I recommend it to all my patients. We also need to discuss technique because for a lot of women who have had bad sex, it's the first time they actually realize that he doesn't really know what to do. Does he know where your clitoris is and does he know what to do with it? And if you haven't told him about these issues for a long time, you can certainly not expect him to know all of a sudden at this age. We ask you about privacy. A lot of people don't have a lock on their door. Again, when I give this talk live, I ask people to raise their hand if they have a lock on their door, and it's usually a very small minority of people who have that. And I think it's essential. I wouldn't be able to have sex with anybody in the house, and if I didn't have a lock on my door. And if we've ruled out all the other problems and we've discovered with you that you don't seem to have any sex issues, then certainly testosterone is on the card. But I don't want you to think about it as the magic solution. You really need to think about what the issue is. I just want to conclude with this, which is just a little reflection on HRT in general. Before Jodorowsky talk, which you're all familiar with, the common idea was that if you take HRT, you will die earlier, and that's why we were so afraid of it. Now it's the opposite. If you don't take it, you will die earlier. And this idea of dying earlier was coming from the fear of breast cancer. This is published on the BMS, the British Menopause Society website, which I do invite you to visit. It's a very useful website. It also has the location of where menopause specialists are, because not everybody has the specialist qualification to talk about menopause. But you can see that the breast cancer risk is actually not as high as people think. It's about 4 cases out of 1,000. These are the second line women who take HRT comparison to the first line. But there are a lot of other risk factors. For example, if you drink more than 2 units of alcohol per day, it's actually a higher risk of breast cancer than HRT is. And if you are obese, that's the second last line down here, the risk is massive. And if you exercise, your risk is reduced. So again, we look at it as a multifactorial disease where loads of other things are important and not just take HRT or not. So at the end of all of this, the decision is different for each one of you. We're not all the same. You need to balance pro and cons on each side of the scale and decide that what you need and what is right for you. And whatever you decide, please make sure that advice comes from a qualified source, because one of the things that menopause has brought in now that is such a common thing is a new breed of experts. Everybody has a book, everybody has a podcast, everybody talks about menopause, and a lot of these people, I'm afraid, don't have the right qualifications and are not too sure about the truth in the advice they give. Thanks very much.
Thank you, Rita, for a very informative talk. I hadn't really realised the impact of ageing on our bodies and how this can impact the symptoms of menopause, and some of them can be very much mistaken. I definitely won't be mentioning the sex scheduling to my husband. He'd like me to schedule it all the time. First of all, we would look at the questions that we had submitted at the registration, just a couple, and then there's a couple that have come through on the chat. So if we could just get to those. So first of all, one of the questions was cardiovascular effects of hormone therapy.
So as I said, there is an effect, and it's a beneficial effect. The only thing about that is the study has shown a beneficial effect if you start early. So this was called the window period. If you start HRT in your 60s, you've lost the boat, you missed the boat. So you have to start it early, and basically in that way you reduce your risk of cardiovascular disease. And that's really important, because this idea out there that you need to take HRT because it's good for your heart, it depends. And remember, the important thing, yes, the study showed benefit. What is the cherry on the cake? The vast majority of the bulk of the improvement is the other things.
Yeah, thank you. What percentage would you know of women are perimenopause in their early 40s? And what would the signs be to look out for? And would you have any does the polycystic ovaries have any differences in relation to the menopause?
Percent, that's a hard question. Well, basically, we're all perimenopausal by the age 45. So 45, okay. Sorry. So I don't think that's that important, because a lot of women come in to me and say, am I perimenopause? Do I need to know? I need to know if I'm perimenopause. And don't worry about it. All you need to worry about is, are you happy? Are you not happy? Have you symptoms that bother you or not? And if you have symptoms, go and talk to a specialist. And the other thing about that is, one of the problem in perimenopause, and I don't know why this is, but it's fashion, like the way things are fashionable one time and things become not fashionable anymore. Same happens in health. I had this discussion with my daughter recently. Do you remember the Crocs that,
Yeah.
the Crocs shoes? I used to
Very
have
attractive.
my kids having them when they were smaller. And then they went out completely. You couldn't possibly wear them. And now they all want them again. Okay, so menopause went exactly like this. In perimenopause, what happens is that it's very hard sometimes to know if the symptoms you're having are due to premenstrual syndrome, PMT, bad periods, or perimenopause. Okay, because these things overlap quite a lot. If you think about PMT symptoms, anger, anxiety, depression, how do you know? And then you talk about menopause symptoms, that's exactly the same. So very often when we talk to women, because we ask specific questions, we are able to understand which one of these two more is. And what happens is this actually is not probably perimenopause. I think is your periods. Let me take your periods away first and see how you feel. And you know what happens? Women don't like that anymore because they want to be perimenopause, but they don't want to have PMT because it's not fashionable anymore. So what I'm trying to say, it doesn't matter. You don't have to have a specific label. If you have symptoms that bother you, they should be fixed. If you don't have any symptoms, do absolutely nothing because you don't have to find out where you are in the journey. And
Lovely.
PCOS is interesting because people with PCOS would tend to usually to have symptoms later. They have more ovarian reserve because they haven't used their eggs. So sometimes they actually start having symptoms later, and that's quite common.
Okay, thank you. Is there a recommended age to stop HRT?
No, there isn't. There used to be that you only take it for 5 years. It's one of the things like we use vaginal estrogen only for 6 weeks or 12 weeks or whatever. We don't know why. We know that the longer you take it, the slightly increased risk of breast cancer there is. So what I say to people is, look, if you're taking it for bone prevention and heart prevention, you definitely should take it until about 60. That's usually what we tell people. And then after that, it really depends because some people stop it at 60 and they have absolutely no symptoms and they're very happy that way. Some people stop it and they still have a lot of hot flushes and nice sweats and they should continue. So it's different for everybody, but there isn't a recommended time to stop it.
Thank you. If we look after our weight, etc., is it safe not to take hormone therapy, and when to take the vaginal hormone therapy? And is there a
Yes,
maximum dose per week?
yes, there is. So, yeah, if you don't take HRT, as I said, go for plan B, absolutely fine. But do use vagina. Start at the beginning, start in your early 50s, okay? Even if you, or when your periods stop, usually. That's a good time to start. Until you have your periods, you probably have enough estrogens not to have any vaginal symptoms, generally. Again, some women might be different than that. It's usually given twice a week, but it can be increased if needed because it's very low dose and is only localized, and your doctor will advise you about that.
Perfect, thank you. Are there any special considerations for surgically induced menopause, hysterectomy, and oophorectomy at the age of 40? I'm now 45.
Yes, obviously, definitely consider HRT because the surgical, it's a bit stronger in terms of an effect on heart and bones because everything is gone so quickly. And usually women who had oophorectomy are the one that we are more likely to give testosterone a bit quicker as well because the ovaries do produce testosterone as well. And it is one of the one that we stop producing later. So with normal menopause, not everybody needs it. Some people don't need it at all. But if the ovaries ever removed, it's usually needed. So definitely I would consider treatment in that case.
Thank you. I am finding it difficult to remember, like I just go blank. It's very embarrassing in work. My mood is low and my weight gain is at least 2.5 stone. I have tried the pill form of HRT, but I'm on patch now. It helps a little, but I feel really overwhelmed.
And that said, these are history we hear every week, and I'm really sorry you feel that way. I don't have a magic solution. The weight, it is something you have to sort out. And I am a great believer that if you can sort out the weight, you will feel better in your mood and the way you feel about yourself. But the HRT is not going to fix that. The difficulty to remember, which was women call the brain fog, it is not going to be fixed by HRT. I have it. I always tell people I've been on HRT for years and I still have brain fog. It is all about being organized. The only time when HRT really helps with brain fog is when your sleep is affected. So if you're really not sleeping well, then usually your memory is affected by that. So it might be that your HRT is not optimized, so it might be worth to reconsider that. But remember what I said at the beginning is not the magic solution. Not all the things on the list are going to go away. And if mood and being feeling low is a big problem, it could be that there is an endogenous component of depression as well. And there is no harm to consider other drugs and antidepressants as well with HRT. It is something we do quite a lot, because just because it happens in menopause doesn't mean that people cannot have depression and other medical situations in menopause. That is, what I mean is not necessarily all due to hormones.
Yeah, thank you. Yes, lots of life changes going on can
Yeah,
impact our mood.
yeah.
Dr. Galimberti, now that progesterone is given with estrogen, is the risk of cancer gone?
No.
Okay.
It
Thanks.
depends on what cancer. Okay, endometrial cancer, yes, absolutely. Okay, but there are some things to worry about. Okay, so and this is something I didn't put in the talk because otherwise you think I'm too argumentative. But one of the trends that is going on is, oh, take as much as estrogen as you want. My symptoms have not got better. My weight gain is not gone, so I need more estrogen. And this is something that make my blood boil, because it happens in this private Facebook groups where people have become expert. There is these doctors in the UK who give people huge doses of estrogen, and the British Menopause Society has now spoken quite clearly on this. It is against guidelines. So the progesterone dose we have and the risk of endometrial cancer is controlled with the normal doses of estrogens, but there is a trend to give higher doses than normal. We don't really know what's going to happen to these patients, and I'm really worried about it because I've already had a few cases of endometrial hyperplasia. And endometrial hyperplasia, because we do ultrasounds in our clinic for women who are on HRT, is when the thickening of the lining of the womb the lining of the womb is thicker than normal, and that's definitely estrogen dependent. So, and that these are women who are on very high dose of estrogen for particularly no reason. So that's about the endometrium. About the breast cancer, risk is same as before, 4 out of 1,000, it makes no difference. There is
Lovely.
this idea again out there that the newer type of HRT do not give breast cancer. Nothing gives breast cancer. It's a least small risk associated, and it is the same with the newer type of HRT.
Thank you.
Maybe a bit less, but not zero.
I think we've got time for one more question. How can a woman in their 50s who has menopause know if her period is decreasing and when to start vaginal hormone therapy?
In the 50s,
You
you
had the
said.
menopause, yeah.
Definitely in the 50s time to start it. If you would just want to use vagina, don't overthink it, just use it. It's like you use it twice a week. It doesn't require a lot of commitment, very easy treatment. There's no harm in starting it a bit earlier.
Yeah, okay. I think that's probably it with all the time we have. Somebody was just saying that they really appreciated your talk.
Thank you.
Brilliant webinar. Thanks for the work you do and conversations you're having.
Thank you so much.
So thank you for coming on and doing our webinar. It's been a pleasure to see you again. And thank you to everyone that joined the webinar. I hope you have a little bit more knowledge now on the menopause. We have the survey if you have a few minutes to complete it. You'll see the link in the chat box. Let us know what you thought of the talk and your experience today. And if you enter, just a reminder, you will get a chance to win a One for All voucher. Just remember there will be a link to today's webinar, which will be emailed out to everybody, and it will also be available on the Health and Wellbeing YouTube channel. Please click the link and QR code for any other webinars you may be interested in. Thank you for joining in, and we look forward to seeing you tomorrow on our next webinar, which is on winter preparedness, health and social care workers vaccinations with Dr. Paul Mullane. Thank you.
Thank you.